Well, good morning, and thank you for being here. You know, we're talking about some totally new things, this being the second program in the United States, and considerably different than the first effort that they attempted, and I think has been very successful down in South Dakota. And as, per usual, what happens is when you've had experience with one thing, you can see all of the issues that haven't been covered or the mistakes that have been made, and you try to change and make it better. And I would like to believe that this program is going to be, at least the way that it's laid out, the fundamentals is going to be a better program than what currently exists down in South Dakota. As Amy said, my name is Tom Nearing. I'm with the North Dakota Department of Health, and specifically I'm the director of the Division of Emergency Medical Services and Trauma. So from the health department perspective, we have all the trauma hospitals in the state of North Dakota, as well as all of the ambulance services. So this particular training falls right in line with basically many of the goals that we have at the Division of Emergency Medical Services. A lot of unique things about this program. You get to see all of the high-tech stuff that's going on. But I have to tell you that the most important aspect of this program, at least in my opinion, is going to be that of the trainers. And so I think we have a relatively small number of people who are going to be trainers, but a lot of the success in this particular program is going to fall directly on your shoulders. And we'll talk more about that as we go along. Okay, I pretty much made the slides just as talking points for myself. So it isn't that you need to copy any slides or anything that's going to be extremely important to the future. But basically what happened with the Helmsley Charitable Trust is that as a health department, we began discussions with the Helmsley Charitable Trust back in February of 2012. Since then, there's been a huge amount of work that's been done just to obtain the grant and then to move forward with the commitments that we made to the Helmsley Foundation. When I say we, it's really SIM North Dakota is what I'm talking about. So we began those discussions back in February of 2012. SIM South Dakota, that you've already heard about, was the first program in the United States. I'm sure that what's going to happen is Helmsley will continue to try to replicate this program in North Dakota and South Dakota to other states. When Dr. Allen was talking earlier about the rural nature that basically Helmsley has interest in, we're really talking about 7 states that they have interest in. And that's usually South Dakota first. That's because Walter Panzier, who is a grandson of Helmsley's, basically is a paramedic in South Dakota, was a paramedic in South Dakota. Now I think he's running a pheasant guiding service. So that seems to be the natural career ladder, from being a paramedic and then getting to have your own operation hunting pheasants. So I wish that would have happened to me. Anyway, so South Dakota was the first program. The way that they're established, and some of this has already been talked about, so a lot of what I talk about will probably be redundant with what Dr. Allen has talked to earlier. But this is from the perspective of the health department. So basically, South Dakota was the first program in the United States, and the way that they are functioning, the way that their system is set up, as you heard, they have 3 trucks and 2 Suburbans, and they're basically owned by different hospitals within the state of South Dakota. So as an example, there are 2 of these trucks in Sioux Falls because both McKenna and Sanford have a truck. There's 1 truck over in Rapid City, and then up in Mobridge there's a Suburban, and right now the other location fails me at this point. But basically what happens is I believe that becomes a far more political environment than what we've established in North Dakota. So one of the things in discussions with Helmsley right at the beginning was, can we put together some kind of approach to this that removes this from the political arena. And at that point in time, in discussions, we had determined that probably the best way to do this was to look at the 4 major cities within North Dakota, the 6 tertiary hospitals, and give everybody an opportunity to participate in this program. So that's what's different about our program versus South Dakota's program. And at least from the beginning, it appears as though our structure is probably the preferable structure as far as setting this particular program up. So North Dakota is second for the Helmsley grant. So what happened originally when the health department was notified, and oftentimes things slide my way, so that's the downhill, kind of slide that occurs at the health department. Basically, I was brought in initially for working with the Helmsley people. And that occurred, as I said earlier, February of 2012. So I knew I knew little about simulation and those types of things, but because I know Tim Shea, I knew that there was a simulator program that was already in place at the University of North Dakota. So I gave a phone call to the Center for Rural Health in North Dakota and talked to Marlene Miller, and it was just serendipitous that she gave me Dr. Allen's name. Again, I didn't know Dr. Allen from Adam, and so I gave him a call. And that was serendipitous because basically I got him out of clinic one day to talk with him about this, and he said, this really is right down our alley. We have a goal of establishing simulation training across the state of North Dakota, and this allows us to achieve that goal. So early on, right in the beginning, in February 2012, we started working together. I will tell you that most of the heavy lifting was done by ND Star, and it was my pleasure to be able to sit on the outside looking in and saying, gee, I think you need to do this. I had one of those positions. So anyway, so the Center for Rural Health was contacted, and I was referred to Dr. Allen, and then discussions regarding this opportunity began with a partnership between the Department of Health and ND Star. So we had a number of sessions where we started doing some planning as to how we could put this grant into play. And one of the things that we recognized early on was the buy-in of the tertiary care hospitals within North Dakota. So just for my own edification, those people who represent All-True, could you raise your hand? Okay, so we have the All-True group over there. Okay, how about people representing Trinity and Minot? Okay, we have the group down here. Then how about those that are representing Essentia and Fargo? Okay, and Sanford and Fargo. All right, then Bismarck, St. Alexius. Okay, I know Deanne. And then representing Sanford and Bismarck. Okay, cool. All right, just so I have an idea of what location that you're from. So moving on, from February to June, basically we did the groundwork for the grant and then completed the application and turned that into the Helmsley Charitable Trust back in June of 2012. It's interesting to note the Helmsley Charitable Trust, John talked a little bit about that, but I'll talk a little bit more. The Helmsley Charitable Trust was founded when Leona Helmsley, who was the survivor of Harry, basically had all of the money and had decided to leave that to her dog. And you probably all remember that at one point in time, way back a long time ago. And the family fought that. And so what happened is it went through a negotiation process, and what was determined is that money should be used as a charitable trust. And that's basically what led to what's occurring now within North Dakota and in South Dakota. Again, South Dakota usually gets things first. We usually get things second. But I believe that there's been an excess of $50 million already spent in the state of North Dakota from the Helmsley Charitable Trust. So it's huge. I mean, everybody can use 50 million. So, and that's why I play the lottery. So far, it hasn't panned out for me. So February 2012 to June of 2012, we did the grant groundwork and the application was completed. And I got to know the people at ND Star very well because we had quite a number of meetings. As I said, most of the heavy lifting occurred from the ND Star staff. So August 2nd of 2012 was the official announcement that we were awarded the grant. That was held here in Grand Forks in this very room with a press conference to announce the Helmsley grant, nearly $5 million for Simulation in Motion, North Dakota. So that began in August of 2012, and there's been a lot of work that's gone on in a little over a year's period of time. Now, just to reiterate something that John said, just to reinforce it to you, is that the tertiary care hospitals, for the first year of the grant, get basically the money that is spent on you as the instructors. They get that back at 100% from the first year of the Helmsley grant. Second year, it goes to 67%, and then basically tertiary care hospitals pick up that third that was picked up by the grant in the first year. And then the third year of the grant, basically it's 33%. So that covers our first 3 years of operation. I think what is really going to be a challenge for us in the future is to make sure that some type of funding exists. I will just tell you from meeting with all of the administrators of the hospitals, the tertiary care hospitals in North Dakota, everybody is pretty much in the same boat. You know, everybody has their funding that's, being questioned and decreased, and the hospitals don't necessarily. I will just give you the example from the trauma situation in the state of North Dakota. The heavy lifting in trauma in the state of North Dakota is typically done by the Level 2 training facilities or the Level 2 designated trauma centers in the state of North Dakota. How long can we expect that to go on? Well, it started basically in the early 90s, and it's occurred up until now. But the hospitals are becoming more reluctant all of the time to continue to put money into those types of programs, and I believe that's justified. We have a great system of care with the North Dakota trauma system, and I think that the people of North Dakota, through the legislative process, need to stand up and take ownership of programs such as this and the trauma program. And currently there's a bill before the legislature with regards to funding for trauma. I anticipate in the 2015 legislative session there will be a similar bill for Simulation in Motion North Dakota. So that's what we're looking at as far as sustainability for the future. So the primary purpose, and again, this is just being redundant, but the primary purpose is to provide education and emergency patient care to all of the critical access hospitals and all of the EMS units within the state of North Dakota. Again, the Helmsley Charitable Trust, basically their focus is on rural and frontier areas. Now, I also serve as a committee chair for the National EMS, it's called the JC-REC, Joint Committee on Emergency Medical Care. And one of the things, I just had a discussion, if we think we're rural and frontier, you should talk to the people from Guam. People from Guam, basically, if you want to see a trauma surgeon, it only takes you a 9-hour flight to Hawaii to be able to see that trauma surgeon. So that's a whole new definition, I think, of rural and frontier. But we do face many of those similar kinds of challenges here within the state of North Dakota. So our primary purpose at SIM North Dakota is basically those rural and frontier areas where typically what is happening more frequently is that there's money that needs to be spent on sending people to training, whether that's ambulance crews or whether that's critical access hospital staff. And again, what's happening is their funds are dwindling, and as a result of that, we feel that this particular program can really help out by taking the training out to them. There will not be a training fee for these ambulance services nor the critical access hospitals, at least in the first 3 years of this grant. Now, who knows what we're going to need for sustainability starting in year 4, but by the time we get through the legislative process, there may also be some fees associated with that. But it's a lot less money than sending 1 or 2 people from your critical access hospital in Divide County, which is Crosby, off to Grand Forks to take some specialized training. Now the training's coming out to them. Note the configuration of the trucks, where the front is essentially an emergency department or an intensive care unit, and the back, which is a replica of the back of an ambulance, and in the middle is the control booth. So you could actually do a pre-hospital education session with high-fidelity human patient simulators, as well as an inpatient or emergency department patient in the front of the truck. Okay, so our secondary purpose then is the sim vehicles and simulators may be used for other educational offerings depending upon the availability of the trucks and the crews. And that basically could be with what we would consider to be the standard programs such as ACLS, ATLS, PALS program, those types of things, so that there is the availability of these resources for the tertiary care hospitals as well. Now, some already have 1 or 2 or maybe 3 simulators, but they don't have it all put together. And so I think that this works very well, doing this out of the back of these vehicles. Okay, so let's talk a little bit about the stakeholders. And who are the stakeholders? Well, to begin with, we thought we would use ND Star as the grantee, and it ended up being called SimND, and basically that is mainly housed out of the ND Star program that already existed. So again, one of the advantages that we have in North Dakota already over South Dakota is we've had a simulation center set up at the University of North Dakota Medical School for a significant period of time. They didn't have that down in South Dakota, so they started with the rural stuff, and I think now they're building into basically a facility for simulation, and I believe it's with the South Dakota Medical School as well. Okay, Department of Health. Department of Health, we are a stakeholder from the perspective of a couple of different things. Number one, we put money into this project. And number 2, we have oversight. And oversight, to me, basically means that any report that goes to Helmsley also goes to us. And so we're able to determine whether this training has been effective, what it's costing, all of those types of things as far as planning for the future. And I do sit on the ND Star Advisory Board, as well as sit on committees such as, doing the scenarios, making those appropriate and those types of things. Another stakeholder are the tertiary hospitals. And quite frankly, my belief is this program already would not be as successful as it is if we did not have the tertiary care hospitals involved. We didn't want to make this political. We didn't want to try to choose in 2 cities between Sanford in both of those communities and Ascension, Fargo, or St. Alexius in Bismarck. That we wanted this to be rid of all of that political burden and instead focus on the education. And then critical access hospitals and pre-hospital providers, for the most part, they're going to be the recipients of this training. And so they are certainly considered a stakeholder. At this point in time, there isn't any demand on them for additional funds nor fees at this point in time. So then the major financial contributors are obviously the Helmsley Charitable Trust, which was almost a $5 million grant for 3 years, University of North Dakota through ND Star, and now SimND, North Dakota Department of Health, and the tertiary hospitals. So again, those are what I consider to be the major financial contributors. There's some other ones. I think you heard Dr. Allen speak earlier of basically they got a grant for this center from Blue Cross Blue Shield of North Dakota. So in many ways, you could consider Blue Cross Blue Shield of North Dakota to be a major contributor as well, even though they're really not involved in SIM North Dakota. They had the simulation center which made all of this possible. Okay, this aspect is something I'm very interested in, and that is team training. For the most part, all training crews will be taught under the same curriculum, and I think that is extremely important. What we have in the pre-hospital arena within the state of North Dakota is I believe we have somewhere in the neighborhood of 285 instructors for pre-hospital curriculum. Okay, that could either be a refresher course, continuing education, whatever the case may be. You can't tell me that those 285 instructors in the state of North Dakota teach everything the same, all of the subject matter, testing, all of those types of things. Same thing is true for the critical access hospitals, depending upon who they're using. Now, it gets a little better once we start getting into programs like ATLS and ACLS for the critical access hospitals, but again, it's kind of a hit and miss kind of situation. A lot of times what they have to do is to send their people out for training. The nice thing about this program, it takes the training to them. So because we're taught under the same curriculum, it'll allow for a standardized curriculum for all emergency providers within the state. One of the things I'm absolutely believe in is that this standardized curriculum, so that everybody is getting the same subject matter, is extremely important as to how we deal with different disease entities and trauma. And I think just as we've seen the popularity of PALS, of ATLS, of ACLS, and those types of things, because the core content essentially is the same, you have a lot of people taught under these programs that really end up being on the same page. And as I said earlier, because of some of the other education that's out there, that doesn't occur. Now, the nice thing about this curriculum is that basically we've got scenarios that have been put forth for nurses. We've got curriculum for EMTs. We've got curriculum for paramedics as we go down the line here. And I think that's, again, extremely important because even though some of those skills may be different, essentially it all emanates from the same place. So standardized curriculum will enhance emergency care throughout the state. You know, there's a lot to be said for standardization of education. When we start to look at who does the best job, it's almost, and if you're all familiar with this as well too, one of the things that a number of hospitals have done is a checklist. So before you do anything, you have to go through your checklist. And some people may say, well, gee, that seems to be a waste of time. But again, it's the attempt to try to standardize the care for those individuals, at least throughout their organization or institution. So a standardized curriculum, I think, is extremely important. And that leads, again, to standardized care. So hospital and pre-hospital being taught under the same curriculum. That rarely occurs now. Even though we are rural in nature, and even though everybody in a small town knows everybody else, oftentimes we isolate ourselves to say, well, this is strictly hospital training, or this is strictly pre-hospital training. And the nice thing is I think this fosters that relationship between the hospital and the ambulance service, something that I think is long, long overdue. And this tends to foster those relationships as well, too. So anyway, so that does foster a team approach. A standardized curriculum fosters a true continuum of care. And before, what has happened is that if I'm a nurse at a critical access hospital, who maybe part of my job is to cover the emergency department, some of it is basically to cover the patients that are inpatient all at the same time, I may work very little with the pre-hospital providers out there. Now that everybody's being trained basically on the same format, I think that will enhance the relationships and understanding between the pre-hospital and the hospital, and as we move down the line to tertiary hospitals, rehab, and those types of things. So whatever we can do, I think, to make sure that we have a standardized format is extremely important. And that's basically what I stated here as far as being more comfortable. Finally, just to finish up team teaching, the approach that is being taken here allows for the most current care knowledge and techniques, assuring every provider is up to date. And whether we'd like to admit that or not, at one point in time, basically the knowledge in emergency care was doubling every 3 years. And it's always a hard thing, 3 years is a relatively short period of time, to make sure every ambulance service and every critical access hospital have the latest knowledge can be accomplished through a program such as this. You'll see changes that occur here, and I'm sure that 2 years from now there will be changes to some scenarios that you're going to be learning about. And the nice thing is that you've got a center that makes it its business of remaining current. So that'll get the word out to the smaller communities as well. Probably most important is the immediate feedback allows for an enhanced educational opportunity. And basically what we mean by immediate feedback is that someone will go through a scenario, and you already have seen the interior of the bus or the truck, and in the midst, between the front and the back, is a control room. So all of the monitors that are being used on the patient are going to be recorded at that time. Video will be recorded, audio will be recorded, and that's an opportunity then for you as the trainer to go through that scenario with the individual or individuals who have basically just gone through their scenario, and so they get immediate feedback now, rather than saying, okay, I'll take a test, and by the way, I'll get the results in a month from now, which means very little to that individual. So immediate feedback, I think, is extremely important. And you're going to find that that's probably, from the teaching perspective, is going to be your greatest opportunity to affect emergency care within the state of North Dakota. That's why I think what we're talking to here is a key group of people, probably the most important people, because you're going to be the ones who are actually out there doing, not only having people go through scenarios, but teaching them based on their response to the scenario that they were given. Okay, so simulation in motion. It's the best possible classroom scenario using high-fidelity human simulators. And some of the positives about this is that basically what we can do is we can mimic rarely encountered scenarios, usually workload dependent. So, which means in some of the smaller organizations, some of the smaller ambulance services, and I'll just throw some real quick numbers at you. Not that this is going to make a huge difference, but I think if we want to talk about the rurality of the state of North Dakota, we have 134 ground ambulances in the state of North Dakota. 14% of those ground ambulances have full-time staff. 86% have volunteers, or a mix, such as they may have one individual who is hired on full-time to be the manager, take care of the education components, all of those other things that go along with an ambulance service. So 86% the ambulance services in the state of North Dakota are run essentially by volunteers. Now, that's a huge, huge number. And the other part of this that I think is important for you to understand is that 50 of those 134 ambulance services in the state of North Dakota do less than 50 calls a year. So if you're doing 50 calls a year, basically you're doing 4 calls a month. And if you have crews where, let's just say you're one crew out of 4, that basically those 50 calls, you're probably only going to have 12 calls under your belt for the entire year. These people are running into things that they've never encountered before. And the nice thing about this classroom training is you don't have to subject a human to, and the harm that could go along with that. You don't have to subject a human to a rarely seen situation. So if you do 12 calls a year, what are the odds that you're going to come up with a STEMI as an example? Or what are the odds that you're going to have, a critical trauma patient? So these are things that can be replicated within these trucks where you can give somebody experience without having hands-on experience with someone else. And as a result of that, basically, we can err without doing harm to a patient. Okay, we've talked enough about bringing training to those that may have decreased educational dollars. And as important to anything is this particular grant and this opportunity fulfills North Dakota STAR's goal and objective of bringing training to all of the rural areas of North Dakota. Again, let me just state what Dr. Allen talked about earlier. The goal is to go to every critical access hospital and every ambulance service in the state of North Dakota within a year's period of time. And that will be repeated over and over and over again with what I consider to be the latest, greatest techniques as far as training individuals in emergency care. Longer range plans, again, the grant is for a 3-year period of time. The goal is to reach every ambulance and every critical access hospital per year. And then the question remains, what are we going to do for sustainability past year 3? And that's going to be something that I'm sure that Dr. Allen is going to be working on. I'm sure that the legislature will be involved in the 2015 legislative session as well. Okay. So that's the end of those stimulating PowerPoint slides. You know, I didn't intend to have death by PowerPoint today, so I think maybe we made it through surviving. But that's just a kind of giving you the overview from the perspective of the State Health Department. We're very excited about this. We think it's great education. A lot of this burden is on your backs, and I understand that you get paid for what you do, but it's going to take very dedicated people to do this training, and you're going to find that there's extreme diversity, depending upon what ambulance service or hospital you go to, between those that may be already amply prepared for emergent situations to those that need all of the help in the world. So, and you're going to find a mix of all of that throughout the state of North Dakota. So anyway, from our perspective, we're very interested in that. Otherwise, we wouldn't be putting money into the pot for this. And we think it's going to really add to the emergency education throughout the state of North Dakota. So, questions? Yes?
So, one question I've actually had already is, are we going to be able to offer CEU hours for these trainings for some of the EMS professionals or even hospital professionals?
We have the responsibility of continuing education hours for the pre-hospital people in North Dakota. My division does.
Yeah,
so yes, we'll be able to do that. You know, and again, it'll probably be on an hour per hour basis. As far as nursing CEUs, I would anticipate that that's something that's going to be applied for as well too. And that's just, you know, basically one more thing. Cheryl, you have something? You go.
What's going to happen is we are applying to, it's CMEs, continuing medical education hours, which qualifies for nurses as well. And so that it will both be for EMS, that everything will be supplied to the state as well as for CMEs. So it is 1 hour for 1 hour. Okay? And all of that will be in the packet of information we get.
Thanks, Cheryl. I think from our perspective, one of probably the groups of people that we haven't talked a great deal about, and that is the physician in those outlying areas. And I really not only encourage you, but hope that we can find some way to get the physician involved in this type of training as well too. Again, that's the continuum of healthcare, and every level needs to be trained. And again, I believe this to be the latest, greatest training, and so I would hope that we're going to see physicians from every organization, certainly the medical directors of ambulance services, as well as those that are either on staff or medical directors of a critical access hospital. I think that's a key position for the future for those people. Okay, other questions? Yes?
Hey, Tom, you're talking about going out and training, the hospitals, the ambulance services. What about the first
There's 86 in the state of North Dakota, and those come under the heading of quick response units. And typically what the law provides for, or rules provide within the Department of Health, is that every quick response unit has to have an affiliate with an ambulance service. So we would expect the ambulance services to include those people. So that hopefully then will get to everybody. Okay, other questions?
What was that number you just spit out? I apologize, I didn't catch it.
I spit out 86 QRUs in the state of North Dakota. So, by the way, as far as critical access hospitals, what we have in the state of North Dakota is we have 44 hospitals in the state of North Dakota. There are 4 native hospitals in North Dakota, and so that basically brings us to 40. Take the tertiary care centers out of there, gives us basically, and I anticipate that we're going to be going to the IHS hospitals as well, because that's part of this program. So that really leaves, if we get right down to it, that really leaves 38 hospitals that we need to hit on an annual basis. So that's the numbers for there. Okay, other questions? Yes?
Why aren't the physicians being involved right now?
Well, I think there are plans for the physicians to be involved. The problem is, Jeff Souther is involved. We don't need anybody else. That's it. So, well, you know, I spent most of my career in hospital and clinic administration. So we're going to have an endless supply of food if we expect to get physicians there, because that's the key. John?
The plan always is to have the physicians involved, and the problem is Jeff and others can tell you, their schedules are a difficult thing. But we want them involved, and the scenarios and everything are planned to have physicians involved so that we can complete that team. I just anticipate a lot of times the docs they may or may not be able to get there. If they can, that's ideal. So when we set the schedules up, we want to encourage the docs to be involved so they can cement that teamwork thing together.
And I think this group as a team, including ND Star, basically needs to have a degree of flexibility in order to be able to get those physicians. So maybe it'll be over a noon hour, or maybe it's 5 o'clock in the afternoon or something like that. But I believe they're a key component. Shelley, you had a question.
I know you said that those that go out on the truck need to have the training, and I totally understand that. Can we take physicians with us as long as there's a full team of the other 3 along with to go out to do training or to connect with those rural facilities to try and draw them in?
There will be a little difficulty with that because these are state vehicles, and nobody can ride in a state vehicle unless they are state employed. Not many of you are state employees, but by taking our course and by us registering you with the state motor pool, you become state employees, so to speak. So anybody who's not a state employee cannot ride in a truck. There's no insurance, and that will create problems with the insurance part of the state motor pool.
Can they ride in their own personal vehicle and follow us? Is that acceptable?
They can come in their own personal vehicle. They won't be able to do the teaching in the truck, but they can certainly help foster things. And again, the thing that we'll point out, this is SimND when you go out there. So when you go out there as your hospital, you're not going out there as Altru or Essentia or Sanford, whatever. You're going out there as SimND. So the thing that we have to be very careful about, and this is from Helmsley on down, is that we can't advertise. So if, for example, Altru has a new cardiac program, we can't take brochures out. We can't be talking about, well, we want to talk about a cardiac program. That's an absolute no-go. We are SimND, and we have to use it like that. So those physicians certainly can drive their own vehicles. They can be in the truck. They can observe. They can't be the educators unless they come through us and work through us. Then I'd have no problem with that.
Let's have a little discussion about that specific point, because first of all, understand that what has so far happened at this point in time is a bureaucracy working with another bureaucracy with another bureaucracy. So if you want to have rules applied to you. Get involved in a bureaucracy. It's really a lot of fun. Anyway, there can be identification though. We don't allow advertising, so the wraps that you see on the trucks basically are going to list the Helmsley Charitable Trust and SimND. And ND Star, yeah. They left the Department of Health out of that, but that's okay. I'm going to be able to live with that. So, anyway, there can be. I mean, you can identify who the crew is coming from, and I believe at one point in time, what they were looking at for a solution, John, was you have the ability to put a magnetic sign on the truck just for that particular training session. Is that correct?
I believe so. Is that right, Amy?
Yes.
Yep. So you can have a magnetic sign from your hospital that this training is something to the effect that the crew on this truck, on the SimND truck, is from Trinity Medical Center or whatever. But you can have it out there while you're out there, but
Right.
and you wear your own hospital name tags.
Right.
So they identify where you came from. You really want to be identified where you're from, because that means a lot to those relationships with those people.
Right.
But your SimND when you're out there, and that's in the grant. That's from Helmsley. We have to adhere to that to keep the money.
So we're trying to remain apolitical, and I think that's a positive thing in North Dakota. But at the same time, I think you need to have some recognition. The other thing that we haven't talked about today is I think that this particular training program is going to do a lot to facilitate relationships between a tertiary center and the critical access hospitals and ambulance services. And, you know, when you meet face-to-face with somebody, you actually have a much greater opportunity to affect that relationship than if they've never set eyes on you, you've never worked together. So I think this also, at least in my mind, and I happen to be a big systems person, I think that helping to build a system of care for emergency patients in the state of North Dakota can really be helped by this type of approach. Other questions?
I have a quick one. So, John, if they ask about our cardiac program, if they ask you, can you tell them? See what I'm saying? I mean, it's a fine line, really, for those that are in our position.
My suggestion is to say, if you'll be around after the simulation's done,
Okay.
we can let you know about that, but for right now, we have to do the simulation.
Okay.
I want to make sure that, you know, I just want to make sure we don't cross that, I want to say political, but cross that barrier so that then it becomes a hospital-based
Right, yeah.
system. And truly in South Dakota, as Mr. Well, as Tom told you, it's that way, but we can't do that.
Okay.
And that's,
And that makes sense. But you know it's going to happen, I mean, especially,
Yeah.
you know, it's...
and I don't have any problems with that. You can say when we're done with the simulation, just come on back and I can talk to you about that. I have no problems with that.
Okay.
So as long as they keep that separately, but we can't have any plans to go out and advertise.
Okay.
You know, you can't have your CEO say, oh, by the way, go out there and do this afterwards, you know. Don't plan on it. Be prepared just in case they ask, but we have to be careful about that.
So, I mean, to kind of get around some of that, would that be a good opportunity, you know, to say, well, this would be a great patient to call a helicopter, not stating which one, or this would be a good situation to get this patient to a cath lab right away, not
Absolutely.
specifying which one, even though you may only be, you know, 30 minutes from Trinity, but, you
Right.
know, so I mean, that's the obvious choice they're going to make, probably, but we're not stating that, we're just saying, hey, this would be a great patient to call a helicopter and get him to a cath lab.
Absolutely.
So that would be appropriate, yeah.
Yeah, I think as long as you're aware of, you know, services that are available within your communities, and if that's part of the continuum of care, you know, as far as being the best alternatives, I think that those things, you know, need to be stated.
Cheryl.
Tom, I'm just going to say that we do have a complete policy and procedure manual that is in
Can you speak up,
form.
She can't.
I can't.
I'll say, we have a policy and procedure manual that's written up, and in, not this week, but in the last week or
Last week.
we're going to be going over, there'll be sessions on the policy and procedure manual. It'll cover a lot of this stuff. So it'll be made clear and it's in writing for you and the whole works. And I'll get back to your question about the helicopter. If you're up in Mohall, talking to the ambulance service there, I mean, it's clear, they're going to call Trinity, they're going to call North Star. So you can talk North Star. You know, I don't have a problem with that because that's all they know. If they mention something else, you know, if they start getting into the political things, you can become more generic. But yeah. And you had a question right here in front.
It'll probably be covered in the policy, but since we're sharing Fargo Bismarck, sometimes people are in the assumption if we have it for that week and it's not in use, that the facility can actually just take it and use it. Does everything have to get booked through?
Yes.
That's what I was trying to say, but I just want to make sure I hear that.
Yes, that is in fact, we have been in discussions with State Fleet and due to regulations and insurance and everything through them in order to make my life a little easier, and I'm not going to have to do the registration and everything. We have to adhere to some of State Fleet's policies, and that is unfortunately one of them, is that all scheduling, be it outreach or in your hospital system in your parking lot, has to come through my office. Obviously, I am going to be on maternity leave for a while.
That must be obvious for me too.
No, I will not be going with 2 baby trucks 2 weeks after the baby's due.
So bottom line, the issue is that, you know, if the truck isn't scheduled to go out and you know, you can do some planning ahead of time. Let's just say that you got an ATLS class going on, and you know that there are parts of this simulator that you would like to take advantage of. I think as long as those things are discussed with Amy so she can do an appropriate job of scheduling, you know, I think that's the secondary purpose of all of this. And we have talked to all of the administrators specifically about being able to use this for their own facility as well. We don't want that to become the primary. We want that to basically be something that can enhance the educational offerings within each organization as a secondary approach, as opposed to going out to each one of these ambulance services and hospitals. Okay, other questions? John?
I think Amy, I'll take up on Amy's comment a little bit. The state motor pool, the state fleet has been very gracious in taking these trucks for us, and they're going to manage them. The alternative is that each one of our hospitals or ND Star would be managing the insurance, managing all the maintenance, handling all the fuel, doing all that stuff. With the state fleet, they're doing it all together. But there is a rule. Every bit of coordination of the truck has to go through somebody who's a full employee of the state. That's Amy. So that's why we're doing it. We're not trying to be difficult or anything like that. If we're going to have them manage it for it and take that out of our hair, that's why that's being done. That being said, we'll talk about it later as well, but you will get to know the Freightliner dealership in your city because the service and stuff will go through there, but it'll have to be approved and everything through. But you know, when work gets done, oil changes, all that kind of stuff, that's the natural process of it. But again, everything has to come through the state office of Amy's here.
And you know, it's inevitable that we're going to have logistical issues, such as maintenance and those types of things. Also, just understand, as I said earlier, one bureaucracy working with another bureaucracy. We'll deal with those issues because such things as the motor pool taking the vehicles hasn't been without some additional effort on our parts. So from my perspective, this group really needs to focus on the educational enhancements and opportunities that you can provide out in those outlying areas. And then secondarily, of course, what can work within your own organization. So, well, in closing, I just wanted to basically make a couple of points. John refers to me as Mr. Tom Nearing. That Mr. kind of bugs me. So, you know, Tom is pretty good. I've lived with that for quite a few years. But anyway, that's just a housekeeping detail. I just want to leave you with this particular thought. The success of this program is all in the educational opportunities that we can provide for those people in the outlying areas. Obviously, we're going to be able to enhance some of the educational offerings within the organization itself, but most importantly, the burden of educating the people across the state of North Dakota falls squarely in your lap. And just think of the fact that you're going to be building relationships with people out there that probably have never been built before. And I really believe in this program from the opportunity of being able to provide educational opportunities that have never been equaled before within the state of North Dakota. So I'm personally grateful that you have chosen to take this on, and I wish you all of the success in the world. So thank you.